Hi class, it's Dr. Lindner. We're still looking at the respiratory tract. So in this short video, we'll just take a look at the trachea in a little bit more detail. And so if you look at the left side, you can see the orientation here of what we're looking at. So here is the trachea. And then we have the esophagus. So this is anterior. And then back here is posterior. So on the anterior portion, we have the tracheal cartilage. On the posterior portion, we have the esophagus, more posterior. And between the trachea or the windpipe and the esophagus, we have this little muscle right here, which is the trachealis muscle. Okay, so again, we have the trachea in the anterior, and in the posterior, we have the esophagus, and between the two, we have the trachealis muscle. And when the trachealis muscle constricts, it can certainly restrict a little bit of the airway. When it dilates and relaxes, then obviously it allows more air through the tracheal opening. Also, when a person is swallowing a lot of food or there's large amounts of mass inside the esophagus, having this soft tissue of musculature back here certainly allows for expansion of the esophagus into the area of the windpipe should the person need it. And here is the larynx. Here is the laryngeal prominence of the thyroid cartilage. Here is the trachea. And if you look at the right-hand side right here, we can look at the flow of things of the branching of the bronchial tree, right? So you have the trachea first, right here. And then after the trachea, we have the primary bronchi. So here's the trachea. And then there's this bifurcation right here called the carina or the carina. And that's involved with the cough reflex. So if something is inhaled here, you can cough it quickly and push it upward. Then we have what's next is our primary bronchus. Here's the left primary bronchus. And here is the right primary bronchus. The right primary bronchus is more vertical and dilated. We said in a previous video, this is where more aspiration injuries take place. If someone with a little child inhaled a marble or inhaled a quarter, most likely they'll be able to find it in that right primary bronchus. Okay, after the primary bronchus are the secondary bronchi. So here's the left secondary bronchus, which is here. So this is primary. And now we have secondary. Here's secondary. Here's secondary. And after the secondary, then we have tertiary. Here's the left tertiary bronchus. Here's the right secondary and a right tertiary bronchus. Okay. After the tertiary bronchus, we have bronchioles. So here are the left bronchioles, and here are the right bronchioles. And then at the very end, we have terminal, right? At the very end is the terminals. Then we have terminal bronchioles. Here are the left terminal bronchioles, and then here are the right terminal bronchioles. Way at the bottom is that skeletal muscle here, called the diaphragm. Again, just another cross section. Here is our hyoid bone, the only bone in the body that doesn't articulate with any other bones. Here's the Adam's apple or the larynx. This is the laryngeal prominence right here. This would be our cricoid cartilage. And then each of these are the tracheal rings or tracheal cartilages, which we see here. Right at, so this is the trachea from here to here. That's the trachea. At the bottom or inferior portion of it, This is where we have the carina. Then you have your primary bronchi. This is the left primary bronchus. This is the right primary bronchus. Then after that, we have secondary bronchi. Okay, bronchi are plural, bronchus is singular. So then this would be a secondary bronchus. This would be the right secondary bronchus. This is just a more of an artist's drawing showing here's the anterior, here's the posterior. Anterior is the trachea, so this is the lumen of the trachea, and here's the lumen of the esophagus. So the esophagus is posterior. Between the two is the trachealis muscle. Okay. And if the trachealis is constricted, it can certainly restrict the flow of air through the lumen of the trachea. But when it's relaxed, it can allow more air through and also allow more room in the esophagus. The lumen of the trachea is lined with pseudostratified ciliated columnar epithelium. So this is columnar epithelium, and you can have these cilia on top of it. And in between, let's say another columnar cell, let's say a nucleus is here, another nucleus is here. So the nuclei are not at level ranges, so it gives it this appearance that it's stratified, but it's really only one cell layer thick, so it's pseudo-stratified. But you can have a goblet cell here, and this goblet cell is going to produce mucus. It's going to release the mucus to allow it to stick to the cilia that are beating rhythmically. Keep that in mind, okay? Okay, so this is a little bit about the trachealis, which is what I explained before. The trachealis muscle exists on the posterior surface of the cartilaginous ring that comprise the trachea. The trachealis will contract and relax, altering the diameter of the cartilaginous ring. The phenomena will alter the volume and rate of flow of the air through the trachea. The posterior surface of the cartilaginous ring face the anterior surface of the esophagus. When food and beverages are swallowed, the esophagus will many times expand into the flexible surface of the trachea formed by the trachealis. This helps to facilitate swallowing. So nothing new, right? If it's contracted, then the lumen goes like this and breathing becomes difficult. When it relaxes, it dilates and makes breathing easier. And if it's relaxed, it will allow food to go down the esophagus because it gives it room to expand. This is a slide of pseudostratified ciliated columnar epithelium. And what we're seeing here is the columnar epithelium. It's not stratified, it's pseudostratified, but we see cilia here. Okay, and these are goblet cells right here. This is the mucus in a goblet cell. That mucus is going to stick here, and the cilia get to beat rhythmically, moving debris. These are cilia. The problem with the cilia is in smokers, that pseudostratified ciliated columnar epithelium, the cilia can burn off. And the whole idea is that as the goblet cells are producing the mucus, they stick to the cilia. When you're breathing in air, the debris, the dust particles stick. They stick to the mucus so that all the debris does not make it down into the lungs. But smoking tends to paralyze and burn off the cilia. It's a big problem. So when they become paralyzed or they burn off, the pseudostratified ciliated columnar epithelium go through this metaplasia. They alter in their shape and size. They go through metaplasia and they end up becoming squamous cells. And you've heard of squamous cell carcinoma. That's not a good thing. This is when the individual, their cilia burn off and there's no more mucus to trap the debris. And in the morning, the person wakes up and they're going, the heavy smoker, right? They wake up because all that stuff made it down into the deeper part of the lungs. So smoker's cough is typically a warning sign. It's typically precancerous, as is metaplasia. The bronchi, the right primary bronchus, I said in a previous video, it's shorter, it's wider, and it's oriented more vertical. And the clinical significance is that more of the aspirations are going to take place where little infants or children can inhale an object and it will get stuck into that right primary bronchus more commonly than the left side. And although there is the carina that's there, it's supposed to be stimulated to cough up any type of debris that tries to make it down. So here is the trachea, and then here's the carina, and here's that bifurcation where it divides into a right and a left primary bronchus. At the superior border of the fifth thoracic vertebra, that's where the trachea branches into the right and left primary bronchus. So that fifth thoracic is a pretty good landmark. Upon entering the lungs, the primary bronchi further divide to form smaller and smaller diameter branches. So remember, it goes from the trachea into that main bronchi, into lobar bronchi, segmental bronchi, bronchioles into the terminal bronchioles. The terminal bronchioles are the end of the conducting zone, and then it gets into the respiratory zone. So here's the conducting zone. Once again, here's the trachea, here's the main bronchi, here's the lobar and the segmental bronchi, and then at the very end, bronchioles and the terminal bronchioles. Once we hit the terminal bronchioles, we're into the respiratory zone, where you have the respiratory bronchioles, the alveolar ducts, which lead into the alveolar sacs, and that's where the oxygen and carbon dioxide exchange take place. Now the lungs, these are the paired organs, and the right lung is going to have a superior, a middle, and an inferior lobe, whereas the left lung only has a superior and inferior lobe. The right also has 1, 2 of these type of separations, or if you want to consider them like sutures, right, of the skull, think of them like that. And then here, this one only has 1, separating into a superior and inferior lobe. The right has a superior, middle, and inferior lobe. Okay, we'll take a break. When we come back, we'll get into the bronchial tree.